All of you all to the second annual Vanderbilt Center for Cognitive Medicine Brain Health Symposium. This year, our title is Mind Matters, Insights into Healthy Brain Aging. My name is Blake Wilson. I'm the Associate Program Manager at the Center and the Community Engagement Specialist. I want to thank all of our participants and our study partners who are here today and for your continued participation. Each day, we are one step closer to finding a cure for Alzheimer's disease because of you. And to our guests, thank you for coming and learning more about us. I want to thank the community partners that I see in the room, those of you from Matthew Walker, those of you from 50 Forward, those of you from First Community Historic Church, Healing Minds and Souls, Meharry Medical College. Thank you all for being here. I want to start by introducing our team, who is supposed to be coming in right now, but they have not made their way. But we're going to start with our director, Dr. Paul Newhouse, Dr. Patricia Andrews, Dr. Joellen Wilson, Dr. Alex Conley, Dr. Sarah Nelson, who's our nurse practitioner, Megan Adams, who we just got from San Diego. She's traveled all the way here to join us from San Diego, with our new program manager. Beverly, who's not here, is our lead administrative assistant. Lauren Mendenhall, who is our clinical translational research coordinator 2. Hannah Sutton, our clinical translational research coordinator 1. Kelly Reeves, our clinical translational research coordinator 1, and Damaris Genevieve, who is also our clinical translational research coordinator 1. So the program, we are going to follow the program as it is written. All of you all should have a copy. We also have passed out little note cards, like little sheets of white paper. If you have any questions throughout the presentations, please just write your question down, and then we'll save all of the questions to the end. And without further ado, I'm going to introduce Dr. Paul Newhouse.
Well, that's an impressive welcome. Thank you very much. It's lovely to be here with all of you tonight. And thank you, Blake, for being in charge of this amazing and wonderful event. It's always so good to meet with you all and tell you about our work and what we're doing and what the news is related to aging and brain health, Alzheimer's disease, and how we're working to help improve the lives of our community and all of you. So what I'm going to do today is talk a little bit about Alzheimer's disease and what the advances and progress we've made in diagnosis, treatment, and prevention in 2025. So this is kind of a report card, if you will, for where we are in 2025. Now, I'm going to start out by sort of asking everyone to take a deep breath because we're in a challenging time. And I'm not planning on making any more remarks about it than that. We know that funding for medical and scientific research is being threatened. We know that that's been an issue that we've been dealing with for quite a while now. Medical and scientific expertise is being questioned, and we have to justify or re-justify and prove the value of what we do and how we do it. But I want to reassure everyone in this audience that our commitment to our patients and to you and to discover new ways to treat and perhaps prevent Alzheimer's disease remains undiminished. And we have sufficient support to continue and complete all of the studies that we have ongoing, and including all of our treatment and non-treatment studies. So I know I've gotten some questions already from your submissions about, what are we in trouble? Are the studies threatened? And my answer to you is no. So we have the resources to continue. There may be some challenges that we cope with, but we are confident that our work will continue and our work will be valued. All right. So with that said, I'm going to dive in then and talk about Alzheimer's disease and where we are. So first of all, I want to just remind everyone about some basic facts about Alzheimer's disease. It's the most common form of dementia. So Alzheimer's is a type of dementia. But it's not the only kind, but it's by far the most common. And it's named for this gentleman in the top left, Dr. Alois Alzheimer. But I also want to highlight another gentleman there, Dr. Solomon Carter Fuller. He's a name that is not as well known, but maybe should be. Dr. Fuller was the first African-American psychiatrist in the United States. He was actually born in Liberia, the son of slaves who had returned to Liberia. He came back to the United States to do his studies, and later joined Dr. Alzheimer in Munich to study the pathology of what later became known as Alzheimer's disease. So Alzheimer described the first case of what later became known as Alzheimer's disease, and the name Alzheimer's disease was bestowed by Dr. Emil Kraepelin, who ran the institute at which Alzheimer and Fuller worked. And Fuller was one of the first people to actually identify the pathology of Alzheimer's disease, and actually pointed out that not every patient with dementia actually had that pathology. And so he was one of the first people to actually draw our attention to the fact that Alzheimer's disease is a common form of dementia, but not the only one. And so I want to honor his legacy and his memory as well. And actually, the American Psychiatric Association has an annual award for Dr. Fuller. But Blake Wilson brought his name to my attention, which I had neglected, and thank you for that, Blake. So we have multiple cognitive deficits in dementia. Memory loss, of course, is the most prominent that we think about. We think of these as memory disorders, but it's not the only one. And we have language impairment, skill loss, planning and judgment difficulties, and sometimes behavioral problems as well. And what Alzheimer and Fuller described was what you see on these pictures, which is plaques and tangles. And the amyloid plaques are collections of an abnormal protein called beta amyloid, or A-beta, and the tangles are twisted versions of another abnormal protein called tau, which is a normal constituent of cells, but it becomes abnormal when it becomes excessive. And these are the two things that Alzheimer and Fuller saw under their microscopes. And they believed, and we believe, that these are the primary problems in Alzheimer's disease to this day. Now, that is not to say that there's nothing else. And this very complicated slide, which I'm not going to go through, is really meant to illustrate the complexity of this disease. And so, whereas plaques and tangles may be the beginning, it's not the whole story. And so much of what we're doing these days in Alzheimer's disease is to try to figure out all the other things that are going on that slide. Now, the amyloid hypothesis, the amyloid cause, this is a timeline that starts with 1906. Actually, it was 1903. This timeline is slightly incorrect. But in 1903 was when these lesions were first described in the brain. But it's all the way to 2021 on the far right of the slide that we start to have a treatment that's focused on amyloid. So it's taken us over a century to get from seeing the first pathology to actually having a treatment that can begin to interrupt that pathology. Now, we have a cascade of biological events that occur in Alzheimer's disease, and if you look at this plot from Cliff Jack, time is on the horizontal axis at the bottom, and abnormality is on the vertical axis. And what I'm trying to convey with this is a process that takes decades to develop. This does not develop overnight. This takes decades, and we're increasingly understanding that the beginning of Alzheimer's disease can be 20, 30, even possibly 40 years before the onset of symptoms. And so we now talk about a preclinical phase of this disorder, of this disease, where people have no memory symptoms, but are starting to have biological changes that could put them at risk. It's kind of like the idea of you don't have a heart attack before you've had decades of cholesterol buildup in your arteries, right? And so we now know that we have to interrupt that process much earlier by putting you on blood pressure drugs, cholesterol drugs, things that interrupt those biological processes that can get us into trouble. So what's the diagnosis and treatment horizon now for 2025? Well, we have some really exciting new ways to make a diagnosis of Alzheimer's disease. When I started in this field, you could only make the diagnosis at autopsy. Nowadays, we don't need to wait for an autopsy. We can actually make the diagnosis with very high certainty when someone is alive, and we can help make treatment decisions based on that. So I'm going to talk a little bit about how we diagnose this in 2025. We have more effective symptom-improving therapies now than we did, although that is still a ripe area for development. We have new medications that can help with behavioral symptoms. We have the first FDA-approved behavioral treatment medications for Alzheimer's disease that we've ever had. That was last year. We have some now new disease-modifying therapies where we can change the slope of decline. We can improve it, so that's a remarkable approach. We're now starting trials of combination therapies. I think this is going to end up like cancer. We're going to have multiple treatments to really get a grip on this illness. And now we're even talking about prevention. And some of you may even be involved in that study here at CCM in terms of helping to prevent Alzheimer's disease. So let me just mention a few of the blood tests that you may have read about in the press, and I've just listed them here. I've listed the test on the far left. What does it test for? What does it predict? And is it commercially available? And so I've listed p-tau217. That's our most promising blood test right now. It tests for the tau protein in the blood, and it tells us actually whether amyloid levels in the brain are high. And it is commercially available now. There is another test to look at the amount of amyloid in the blood, and that also is commercially available. There are some other tests that are exciting but are not yet commercially available. One of those is called NFL, for neurofilament light. That tells us how many brain connections are damaged in the brain and how much of those synaptic connections between nerve cells are lost. And we have one called GFAP, or glial fibrillary acidic protein. There's a name for you. And that tells us about neuroinflammation. Because we think inflammation in the brain is actually part of this problem. And then finally, there's genetic test, which actually has been around for about a decade, but is now more commercially available, which actually tells us whether someone has one of the risk genes for Alzheimer's disease, and that's the ApoE4 gene. Now, the ApoE4 gene, just to clarify, is a risk gene. It doesn't tell you you have the disease. It just tells you what the level of risk is. And so if you have the 4 version of the gene, you have increased risk. If you have the 3 or the 2 version, you have lower risk. Doesn't mean you can't get Alzheimer's disease even with 3.3 or 3.2. It just means you have a little bit lower risk. And so ApoE4, 1 or 2 copies, seems to be the bad actor here. And we do find a high percentage of people that have that. Now, the other way that we make the diagnosis now is to use brain imaging. And we have radio tracers now, which can actually bind to those 2 abnormal proteins in the brain and light up and show us where they are. And so on the left is the amyloid PET imaging, and that is where we inject a radioactive dye into the body, and that is absorbed by the brain, and then is taken up by the amyloid, if there is any amyloid in the brain. And so on the left of that picture is a negative scan, where it's just taken up by the white matter structures in the brain, and then a positive scan would be on the left, and that's showing you. I guess that doesn't show on that. Okay, so but if you look at the left side of the screen of that image, the one that has all the orange on it, that's a positive scan. And then the other type of scan, more on this side of the screen, on the right side, is a tau tracer, and that actually binds to that other abnormal protein, tau, and that can show us the presence of that as well. Right now, we don't use the tau scan as much for diagnosis or treatment planning, but we do use the amyloid scan. That could change in a few years, but right now we're using the amyloid scans to help qualify people for treatment. All right, let's talk about drug development and what's new in the medication realm. First of all, I want to explain that drug development is a very long process. It takes well over a decade to take a drug from discovery to the clinic. And we've been involved in that here at Vanderbilt ever since I've been here, since 2011, in terms of developing new drugs for Alzheimer's disease. And we run a lot of the clinical trials and we're part of a large clinical trials network called the Alzheimer's Clinical Trials Consortium that helps test these drugs to see if they can be helpful to our patients. This is a figure which I know you can't read, but I want to illustrate all the number of drugs that are being tested for Alzheimer's disease. This is by my colleague Jeff Cummings. He puts out this figure every year, and he tries to show what's in clinical trials. And so as you start from the center, that's phase 3, that's the most late stage trials, and going outward you get from phase 2 to phase 1. And so you can see every little colored dot there, or colored square, is a drug that's being tested. There's a lot going on here. And then this is another slide from Jeff's article where he shows you, if you read down that list, these are all the different types of biological processes that are being tested for Alzheimer's disease. So, circadian rhythms, oxidative stress, metabolism, inflammation. You can see that it's not just all about amyloid and tau now. We've gone beyond that. We're going to the next stage. So we have treatments that are being developed in all sorts of different areas. Now, many of those won't work. I have to tell you that. I mean, the reality is that most of the time we fail. Or we find that the juice isn't worth the squeeze, right? So that there's not enough of a benefit to justify going forward. But this is where we are today in 2025. We are now trying to remove all the stuff that's on that colored figure there, that brain on the top right. And the way we're doing it is we have several different approaches. So one of those is to try to reduce the production of beta amyloid. And there have been some attempts to do that. They haven't worked yet so far, or they've had too many side effects. We're trying things like even partial gene silencing. We're even about to launch a study here under Dr. Wilson's leadership where we will actually try to partially silence the gene that produces beta amyloid to see if we can reduce the load, as it were. And then we can keep it from glomming together in a plaque, and that's that middle area. And then finally, the most successful so far is this last one, which is immunotherapy, either active or passive, where we're actually trying to take out the garbage. We're trying to remove this stuff from the brain and to see if that interrupts this inflammatory, toxic process that is damaging the brain over years and decades. And so you're going to hear about that. And that immunotherapy is done in two ways. You can either give somebody an antibody, like we used to do in the old days with gamma globulin. Everybody remember gamma globulin, right? So that's giving you antibodies. It's what the mother does to the fetus, right? The mother gives her antibodies to the fetus. And so we give you an antibody that's made in cells, and that helps the body remove beta amyloid or amyloid beta from the brain. We're also exploring ways to actually use your own immune system to immunize you against this toxic protein and have the body's own system remove it. So either way, right now the passive way has been working better, but we're exploring the active way as well. So one of the things we've learned in the last couple of years is that if this antibody treatment is going to work, it has to really drop the amyloid level in the brain. If it only drops it a little bit, nobody gets any clinical benefit from it. It has to really take it down to the floor. And so that what we've learned is that the benefit, which is that orange dotted line, you're only going to see that benefit if you get that green line that comes all the way down to the bottom in terms of that amyloid negative threshold. And so some of the early antibody studies that failed because they didn't work well enough. So the antibodies were lousy, or they didn't get into the brain, or they didn't, the early antibodies that we tried because we've been trying antibodies now for 20 years. And the early ones all failed because they just didn't work very well. And people had to go back to the drawing board and design better ones. But we're now there, and so here are the two FDA-approved drugs called lecanemab and donanemab, and they all reduce the progression of this illness by about 35%, 30 to 35%, which you might say to yourself, well, that's not very much. But it's way better than where we were before, which was 0. We couldn't stop the progression at all. And so have we made enough progress? No. We need to make a lot more progress. We want to get it to 50%, 75%. We'd like to stop this disease in its tracks. But we're getting there. And I think the route to doing this is combination treatments, and we'll hear more about that. Can we actually prevent Alzheimer's disease? So now, with the tools that we have, we can actually detect amyloid in the brain in people that have no memory symptoms at all. And so the question is, what happens if we put those people on antibody treatments and remove it? Will that prevent them from ever developing memory loss? And that's what we're testing now in the AHEAD trial. And you'll hear about the progress of that in a few minutes. So we're actually, this is the second big trial but the first really one that I think has a chance of success of preventing the development of Alzheimer's disease before it starts. I want to say a little bit of a word about Down syndrome. We have become very interested in Down syndrome here at the Center for Cognitive Medicine because we realize that our friends with Down syndrome are at extremely high risk of developing Alzheimer's disease. And the reason they develop Alzheimer's disease is because they have an extra copy of the chromosome where the gene for amyloid is coded. So unfortunately, chromosome 21 is where amyloid is, that's where the gene sits. And so they have an extra dose, if you will, of amyloid protein. And so they are at very high risk. And so we, along with our colleagues nationally and internationally, have launched a consortium to try to also start preventing Alzheimer's disease in folks with Down syndrome. And so we're very happy to be part of a large international consortium to do this. And Dr. Wilson will be having more to tell you about that in a few minutes. So let me end by talking about what we can do to reduce our risk for Alzheimer's disease, and that applies to me just as much as it applies to you. My father died of Alzheimer's disease, and so anything that I can do I'm certainly going to do. And Dr. Connolly is going to be giving a more specific talk at the end of the evening about this. But just to say a few words now, we think that regular exercise is very valuable and very important. We think that maintaining a healthy heart is critical. In fact, there's numerous studies now that show that blood pressure control alone can reduce the risk of dementia significantly. So blood pressure seems to be critical. A less Southern American diet seems to help, I'm afraid. So a Mediterranean diet, which doesn't mean you have to go and live in the Mediterranean, but high in vegetables, fruits, legumes, beans, fish, low alcohol intake seems to be critical, as well as, and of course, exercising your brain, intellectual engagement. And there's one thing on here that I should have put on, but I realized, but I forgot to, which is your hearing. So one of the data that's accumulating shows that hearing loss is one of the biggest risk factors for memory impairment in aging. Hearing loss alone. In fact, there was a big study that came out last year that showed just by giving seniors hearing aids, you actually improve their cognitive function. Now, I just went and had my hearing tested today. And the audiologist said to me that I have the hearing of a 20-year-old. And I said, keep talking. Is there any other aspects of me that are like a 20-year-old? So hearing is very important, critically important. My dad lost his hearing starting in his 60s, and I think it really contributed to his dementia. Absolutely. So let me end by saying, well, how do we slow down or stop Alzheimer's disease? I realize I'm preaching to the choir here, but join a study. Because if you look at that funnel, to run the studies that we have in the United States that you saw earlier, we would need to screen 7 million people to get all the way to the bottom of that funnel to where we have enough people to participate in our clinical research. So it's a very big funnel to do the studies that we need to do to make a difference. So with that, I will stop and pass it back to Blake Wilson, and we'll have a chance for questions at the end. Thank you.
Thank you, Dr. Newhouse. So now we are going to switch to our Citizen Scientist Awards. And this year we are happy to recognize 7 Vanderbilt Center for Cognitive Medicine 2025 Citizen Scientist Award nominees. So the concept behind the Citizen Scientist Awards is simple. We can't find cures for Alzheimer's disease without clinical trial participants. 90% of Alzheimer's studies are delayed due to insufficient recruitment, making research participants the key piece of the puzzle. We hope that their stories inspire you to get or stay involved in research opportunities. So our first nominee is Mr. Mike Geske, who unfortunately could not be here tonight. But Hannah nominated him for the Cornerstone Award. This is a clinical trial participant who has personally made extraordinary efforts to support local research and participate in a trial. So Hannah's just going to come up and tell a little bit about him so that when he sees the video, he sees that he was recognized.
Hello, everyone. My name is Hannah Sutton, and I'm currently the coordinator for the START, MIND, and Libby studies here at CCM. The individual I nominated for the Cornerstone Award is one whom I have met only recently, but is not someone who is new to our team or to Alzheimer's research. Mr. Michael Geske completed participation in our MIND study, which is about a 2-year-long study, and he has also begun participating in the START study, which is another 2-year-long study. Mr. Mike lives 4 hours away in Missouri, and he has been making the 8-hour round trip for over 2 years now. And every time he shows up, he has a huge smile on his face. Mr. Mike's dedication to research comes from his father's own journey with Alzheimer's disease, and his passion and joy for contributing to Alzheimer's research is evident in every encounter. It has been a joy working with him, and I am so humbled to be honoring him tonight.
Thank you, Hannah. Our next nominee is Evan Dewey, and he was nominated by Kelly Reeves, and he was also nominated for the Cornerstone Award. And unfortunately, Evan cannot be here tonight as well, but Kelly is going to give us a little information about him.
Hi everyone, I'm presenting the Cornerstone Award to Evan Dewey. This award honors his efforts in supporting local research and participating in the TRACK PS and debate clinical trials at VUMC. Despite the challenges of long testing days and traveling from Atlanta, Georgia, he has shown great resilience and dedication. His personal commitment to understanding his condition, proactive engagement in various studies, and desire to help future generations demonstrate his invaluable impact. Congratulations, Evan, on this well-deserved recognition. Round of applause.
Thank you. So our next nominee is Jane Fox, who was also nominated for the Cornerstone Award. And I believe Ms. Fox is here. So Laura, if you want to come up, and I will get the award.
Hello, everyone. My name is Laura Mendenhall, and I am the study coordinator for the AHEAD 345 study and the APEX study. I'm so lucky to be involved in research studies that have the kindest people and who are so passionate about research. I have 3 nominees today, and all of them come from the AHEAD 345 study, which is incredibly time-consuming and not always the easiest to be a part of. I'm grateful to all my participants in these studies, or all participants in all of our studies, but would like to highlight these specific people for their efforts and involvement. So, as Blake said, I would like to start off by speaking about Jane Fox, who is a recipient of the Cornerstone Award. As a Cornerstone nominee, Jane is recognized as someone who has made extraordinary efforts to support and participate in local research. Jane became involved in Alzheimer's research about 20 years ago at the University of Wisconsin and has continued volunteering after she and her husband moved to Nashville last year. She has been very open about how Alzheimer's have affected her family, and while the study is a very large commitment, it has caused her to have a more positive and hopeful view for her own health as well as for her family. Jane is an incredible woman with so much strength and joy, and I'm incredibly thankful to have met her while working on this study. Thank you, Jane, for being amazing. Jane, if you'd like to stand up, Blake has something for you. My next participant is her husband, Mr. Fox, so Tom Fox. So he is a recipient of the Collaborator Award. This is for our study partners who go above and beyond the call of duty. Tom has also been involved in Alzheimer's research for about 20 years and has continued to support his wife, Jane, as she became a subject in the AHEAD 345 trial. He has been nothing but supportive of Jane and attends every single visit and infusion, which I have to say is twice a month for about 4 years. So they come here a lot. Tom brings humor to every single situation, and I'm always so happy when I get to see them both. I see Jane and Tom as a team of people who are incredible advocates for our area of research and who have been involved in the community for an incredibly long time. It is always a joy to visit them on their infusion days, and I'm always grateful about how much they care for each other, or I'm always struck about how much they care for each other. And that makes me happy and very excited to celebrate them in their journey with our studies. Tom is here, and he would like to, he's already set up the grab his phone. And then my final honoree, I've got 3, last person. She unfortunately could not be here, but her name is Ginger Penley. And she is also a recipient of the Collaborator Award, which, as a reminder, is for study partners. As a study partner, she also attends every single infusion or visit with her husband, Keith, who is shown over here. Ginger has always expressed how important it is for her to be involved, as she does not want her husband to feel like she is going through this alone. She is incredibly involved in she's incredibly involved in the caring of his mother, who has had Alzheimer's disease for quite a long time. But she shows me how easy it is to be positive when it's hard to be positive. She is his advocate, and she does not hesitate to ask questions in real time so she can get all the answers she needs to feel comfortable in the studies that we have. Again, while she is unable to be here tonight, I still wanted to recognize her for her outstanding commitment to Keith and to being a support system for our research studies. So a big round of applause for them, even if they could not be here.
Okay, my name's Alex Conley. I'm one of the faculty here at the Center for Cognitive Medicine, and I'm honouring Ms. P.J. Olson with a Catalyst Award. The Catalyst Award is for a clinical trial participant who fights for a cause and is an advocate for trial participation in the community. And I can't think of a better person from one of our studies called the CHAMP study, which is looking at sort of the increased risk for women in Alzheimer's. And as I said, I can't think of a better person to honour as a research catalyst as PJ. She's tirelessly advocating for the importance of brain health, and despite the risks and the challenges with the development of Alzheimer's, and is very interested and committed in advocating to get to that cure that we're all hoping for. So I just want to thank her for all of her efforts in that role.
And our last nominee is Miss Margaret Johnson, who I nominated. She brought her own cheering squad. Miss Johnson, I nominated for the Champion Award. And the Champion Award is a clinical trial participant who acts as a stimulus in bringing about or hastening a result through creative, new, and novel approaches to encourage clinical trial participation. So you could come up, I met Miss Johnson. Thank you. I met Miss Johnson at Matthew Walker maybe last year, and when I walk in the room, I can just sit down because she will tell everyone, you need to be involved in research. You need to have a memory screening. You need to listen to what this girl is telling you to do. But I just really appreciate all your encouragement, and has completed a trial. She's a finisher, and we are still working on new trials for her. So I just want to thank you for your participation, and thank you for always being there for me. So now we are going to continue with our Alzheimer's disease studies at the Center for Cognitive Medicine with Dr. Andrews.
Hello, everybody. Thank you so much for being here. I have the pleasure of telling you a little bit about the studies that we currently have in Alzheimer's disease. So I'm going to start with START. Of course, I had to start with START. So we started recruiting for START at the end of February. So START is CT1812, which is a drug that how do I describe this without going into a lot of medical terms? But it competes for the receptors of the amyloid, so then the amyloid doesn't accumulate in the brain, and we can prevent from amyloid being toxic in the brain. It's for people with mild cognitive impairment or Alzheimer's disease between the ages of 50 and 85. As part of the screening in the trial, we obtain biomarkers for Alzheimer's disease because we do, this is not for all dementias, for Alzheimer's disease specifically, so participants have to have a level of amyloid in their brain. So either by amyloid PET or plasma, or if participants have lumbar puncture that was done on the clinical setting, that is also a biomarker that we can use to screen them into the trial. CT 1812, it's an oral medication. And if anybody's interested, we're currently recruiting for this. This is part of the ACTC, Alzheimer's Clinical Trials Consortium, which we have been a site since 2023. As part of ACTC, we also have AHEAD. This one closed recruitment in 2024. AHEAD uses lecanemab, which is a drug that was approved by the FDA for the treatment of Alzheimer's disease in patients with MCI and or mild cognitive impairment and mild dementia. But AHEAD is seeing if lecanemab in participants that do not have functional or memory symptoms that are completely what we call cognitive normal, but do have increased amyloid in their brain. If those participants that receive the lecanemab for 4 years are less likely to develop the disease or slower. Like I said, we closed recruitment in 2024. Participants come here every 2 weeks for 2 years, and then every 4 weeks for 2 years. And then after that, we do offer an open label extension. Some participants in other sites are already in the open label extension. Our first participants will start the open label in this summer. The baseline data is going to be available to us researchers starting October of this year. So we already have, in ACTC, we have work groups, and how are we going to be looking at this data so we can start publishing it and bringing this data of the baseline information as soon as possible. EVOKE and EVOKE Plus, this is the Novo Nordisk study that we have with semaglutide, which is commercially called Wegovy, Ozempic. It's a GLP-1. So we believe that diabetes and Alzheimer's disease have some similarities in that chronic inflammation and changes in metabolism can worsen cognition. So with this, we're testing if this drug versus placebo can change cognition and function in these patients. There's close to 4,000 participants in over 300 sites, and enrollment closed almost 2 years ago, and the trial will be completed next year. Now I'm jumping to one of our observational studies. So this is not a trial. We do not give any medications for participants involved in ATNI, but we do track them over the years with a lot of neuropsychological testing, a lot of imaging, a lot of biomarkers, and all this information gets put in a database in which all researchers all over the world can use this data to be able to inform the clinical trial. So it's a very important study because we have with hundreds and hundreds of thousands and thousands of data that we can use for to learn more about the disease. Enrollment for cognitive normal. So actually ADNI has been going on for 21 years. So it's had multiple phases according to the different grants. So we're currently in ADNI 4. ADNI 4, the cognitive normal, we closed enrollment just a couple of weeks ago. But we're continuing with mild cognitive impairment participants and participants with dementia. And the team is already planning on ADNI 5. Which we'll likely be a part of. What else about ADNI? Yes. Libby, it's a different type of study because this is for treatment of behavioral symptoms of dementia. So this is for participants that have more advanced stages of the disease. We use THC and CBD versus placebo for the treatment of agitation. Agitation meaning participants that have restlessness, that have what we call significant sundowning, that sometimes resist care, that have anxiety, and it's for hospice eligible participants. So they don't have to be enrolled in hospice, but are in end of life, either because of advanced stage of dementia itself or for other reason, cardiac issues, cancer, or so on. It's 12 weeks with the possibility for open label extension. And last but not least, the MIND study that we have the overall principal investigator for the whole study, Dr. Newhouse. So this is using nicotine as an transdermal form or nicotine patches worn during waking hours. Recruitment closed in 2023. This is a study that's been running on, for a long time. We're the last site, the first and the last site. Our last participants will be finishing this summer, and so the data for this study will be coming on soon. Over here. Yeah. And I'll pass it down to Dr. Wilson so she can share about the Down syndrome studies.
Good evening. I'm thrilled to talk to you briefly about some of the research that we have for individuals with Down syndrome. One, to understand how Alzheimer's disease may manifest itself in our friends with Down syndrome. And then we're in the early stages of developing clinical trials and working with partners who are establishing these clinical trials to hopefully prevent and treat Alzheimer's disease and Down syndrome. So the first study I want to talk about is TRACK-DS, or the Trial Ready Cohort for Down syndrome. This is a part of that ACTC network that Dr. Andrews and Dr. Newhouse were talking about earlier. We're thrilled to have been participating in TRACK-DS for some time now. It's a non-interventional study, so this is not a trial. This is a cohort where we enroll people who are at risk for developing Alzheimer's disease and have Down syndrome. So we're enrolling individuals aged 25 to 55 with Down syndrome. They complete 4 study visits over almost 3 years. And the purpose of the study is to evaluate how the brain changes over time and how biomarkers may accumulate in the brain and in the body. The whole goal of the study is to create a cohort of individuals who we know a lot about them. And we know who is at risk for developing Alzheimer's disease, so that when trials for our friends with Down syndrome become available to test treatments and prevention treatments for Alzheimer's disease, we know who would be eligible to participate in those trials. So TRACK-DS is an incredible study that's already helping us identify individuals who are eligible for potential trials. And so I'll talk about one of those trials right now, the ABATE study. So this is the first prevention trial for Alzheimer's disease and Down syndrome that we participated here at Vanderbilt. And I believe it's one of the first trials in the country. So the ABATE study is in conjunction with ACTC and AC Immune, which is the pharmaceutical company. It is essentially a vaccine. So it's a vaccine that we administer to individuals with elevated amyloid, and we have ways of testing and understanding who already has elevated amyloid. They get the vaccine, and it causes the body's immune system to develop antibodies against amyloid. And so the idea is that it might help prevent some of that amyloid from clumping together in the brain, and perhaps even clear some of the amyloid that's already there in the brain. So we're feeling very hopeful about this trial, and we're already screening and ready to enroll a participant in the trial. I will just say just a word about the future of Down syndrome research and Alzheimer's disease research in Down syndrome. I think it's very promising. I think the future is very bright. So we know that our friends with Down syndrome have a markedly elevated risk for developing Alzheimer's disease. In fact, some of the estimates I've heard lately is that by the 4th decade of life, about 60% of them already have significant Alzheimer's disease pathology. So we urgently need to find a cure, and we need to find prevention for Alzheimer's disease in this population. I'm hopeful that we will start another trial in this population using that mechanism that Dr. Newhouse talked about, that gene silencing mechanism. So we're prepared to launch a trial using that new and novel mechanism in this population, hopefully this summer. We're in the final stages of getting that approved. And then my hope is that later on this year or next year, we will participate in another trial that tests an antibody to reduce amyloid burden in individuals with Down syndrome. So I'm feeling very hopeful about the future of this research. We are thrilled to partner with you all to get this important research done, and I'm happy to talk with anyone who's interested in talking about these studies afterwards. So, thank you.
Okay, I'm back. So I just want to talk a little bit about the CHAMP study, or the Cognitive Health After Menopause study. And this is our study where we've been focused on the risk of Alzheimer's disease, or the increased risk that women have for developing Alzheimer's disease. So let me just give you an explanation of why we approached the National Institute on Aging to help us fund CHAMP. So on the left is the estimated lifetime risk for Alzheimer's disease in men and women. The purple bar is women, the tan bar is men. I think you can see they look different, right? So at age 45, the risk is about 20% for women in their lifetime. It rises at age 65 to 21%, and for men it goes from 10 to 11.6%. So for reasons that are complex, and I don't have time to go all the way into it here, but we think there are a number of risk factors that are unique to women. Now, on the right side is sort of what happens after you get diagnosed with Alzheimer's disease, and unfortunately the news isn't as good there either. So worsening is up in this graph, and the green line is women, and the darker line, brown line, is men. And so women actually get worse faster than men do also. So when women are more likely to be diagnosed and will progress faster. So there are a lot of complex reasons for this. We've actually published on some of this work ourselves. We think that women, for example, spread tau protein in the brain more effectively than men do, for reasons we're not entirely clear on. But my colleague Seppi Shikui, who is no longer at Vanderbilt, but she showed this about 5 years ago using some of the ADNI data that Dr. Andrews talked about. That data actually helped us prove that women spread tau protein through the brain faster than men. So this is the CHAMP study. So this examines the relationship between Alzheimer's disease biomarkers and the cholinergic system and cholinergic integrity. And we think basically women can follow two paths here from middle age. They can go to the good path, which is the green upper path, where there's not much in the way of Alzheimer's disease biomarkers in the brain or amyloid. And then the unfortunately more negative path, which is on the lower direction on the right, where it shows that they develop impairment of this cholinergic system in the brain, which we think is important for learning and memory. And so we've just closed enrollment a few months ago for that study. We're finally enrolled everybody, and now we can start to crank on the data. We're actually unblinding the study. We're looking at our brain imaging data. We're about to look at the blood-based and genetic markers. In fact, Dr. Conley and I were just on a call yesterday where we're working out who's going to do those analyses for us and where's the genetics going to be done. And some of that work is going to be done here at Vanderbilt, the genetics, but the blood tests are going to be done at the University of Vermont lab. So we're going to be doing some exciting work there. Here is some very early data that Dr. Connolly did for us, where he looked at one of our biological markers, which is a novel type of PET tracer that we developed here at Vanderbilt, and which many of the women in CHAMP participated in. It's called FeOBV. It's I won't bore you with what that translates to, but it allows us to actually see the cholinergic cells in the brain in a living human. And basically what we've already been able to show is that the FeOBV marker declines with age, which we would expect, and it also seems to be related to memory performance. And so the lower the FeOBV, the lower the performance, and we think that's very important as well. So much more to come in 2025 now. As I said, the analysis of the biomarkers begins starting this month, hopefully. The analysis of the brain imaging begins midsummer of this 2025. We're going to be making another invitation for those ladies that have been in CHAMP but didn't participate in our FEOBV PET to have another opportunity to do so. We got some additional funds to do that. And we plan to submit, fingers crossed, to the NIH in 2026 for a longitudinal study where we'll invite these ladies to come back and see what's changed, if anything. And so stay tuned for that. Again, much more to come. And when we get the results, we'll be inviting all of our CHAMP participants to come back and learn more. So with that, I will turn it over to Dr. Conley.
I think I'm the closeout speaker for this evening. I know we want to spend some time doing some questions, so I'll try to get through my 2 sets of slides in a reasonable time. I'm briefly going to talk about something that is very much in-house for us, which is what we call the COMET study, which is computerized memory training for the enhancement of memory performance in people with mild cognitive impairment. This is not a drug trial. This is a computerized training trial, and what the aim of this is to potentially be an augmentation to some of these other treatments that are coming through, like the Leqembi and these antibodies that are coming through. One great thing about sort of cognitive training mechanisms is that there isn't any sort of adverse events that could happen with an interaction with a drug because it's not a drug. But to do these sorts of testing, the first thing we need to do is to see whether this is a feasible study in adults with mild cognitive impairment. So we used a computerized training tool called NeuroFlex, which was developed at the University of Cornell and University of Utah. And we looked at a small sample of adults with mild cognitive impairment. And I will say it is an intensive trial of training. So it's very much not 1 or 2 hours a week. We refer to it like rehab, just like if you had a shoulder reconstruction and you needed to do physical therapy every day. We want to approach that memory impairment the same sort of way with this. So we're looking at about 7.5 hours a week to 8 hours a week of training, and we were looking at also some sort of endpoints of the sort of cognitive and functional tests that we do in all of our trials. So we finished this trial in December last year. I can talk about some of the results we've found so far. So our top line, I guess, is, was it tolerable and feasible? Do people who have small memory complaints, will they do this? Will they complete those 45 hours in training? And on the whole, yes, which is great to see. So we had about an 84% completion rate. As you can see, we had a rough, almost even split between men and women. The average age was around 73. And the people who did not continue and complete the trial, the 3 who did not, we saw that they tended to drop out quite early. So we do see that people who are motivated, they do tend to progress through and really complete this trial. So that was really the most encouraging results for this trial. But we also found some nice potential markers to look for in the future, some potential improvements. So, as I said, we looked at a lot of different functioning or behavioural and sort of functional measures that both participants and their study partners rated. So I can show, if you see on the top left here, we had a questionnaire that sort of rated people's personal strengths, and that sort of marker is their self-confidence and their self-worth and their willingness to try things. And between baseline and then the 6 weeks of post-treatment, this increased. People's own opinion of themselves and their confidence increased. They also seemed less tense on the second of these graphs in the centre. They seemed a bit less tense at post 6 weeks of training than at the beginning. And then this third graph on the bottom right is not the participants themselves, but the study partners. So friends, spouses, family members rated that they saw less of the problems of dementia in their loved ones or friends that they saw at the baseline, which is all really encouraging. In addition to that, we also saw what we call cognitive effects. So like on those paper and pencil and computerized tasks, we saw that participants also were more accurate in how they responded to a couple of different sort of memory and inhibition tasks. So all of this is really encouraging. We want to take this to the next step, for lack of a better term, which would be to then test this sort of trial against what we call a control, not exactly like a placebo, but would be a sort of intervention that would be not exactly the same sort of training, and then test it against that to see if it performs better. So as I said, this was a collaboration between both Vanderbilt Center for Cognitive Medicine here, as well as some people at the University of Utah. So we're very much interested in sort of continuing with this work. All right, I will continue on. As Dr. Newhouse mentioned before at the beginning, and Blake as well, I think, we're going to be talking a little bit at the end before we have some time for questions about sort of some of the potential ways that we can be encourage sort of resilience and some level of protection against dementia. So this slide here was from the Alzheimer's Association's facts and figures from this year. And as you can see, up the top, there are a number of factors that we can't really modify. We can't modify someone's age. I know we all would like to not age as much or as quickly, but we cannot modify that. We can't modify our genes. We can't modify our family history. But everything below that line in the purple are potentially modifiable risk factors that everyone can potentially engage in, although some caveats there, obviously. But I'm going to be talking about a number of these different factors. And I will say that among this list, a lot of them feed into each other, and they are interrelated. So things like cardiovascular health is related to hypertension, is related to diabetes and physical activity. But over the next few minutes, I just want to run through some sort of evidence of both the risk, but then also the ways that we can combat these risks. So I guess I'll start with the cardiovascular health at the beginning. So the brain is quite greedy in terms of blood. It's not 20% of our body mass, but it gets about 20% of our blood. We want that oxygen all the time and the nutrients, but all the vessels that bring that blood to our brain, some of the bad things that can affect those vessels, the plumbing, basically, for lack of a better term, can cause downstream effects in the brain. Obviously, stroke is the thing that often people think of, but also just general high blood pressure and other things will push the pressure further from the vessels, from the plumbing, into the brain itself. So one of the strongest sort of risk factors for future development of dementia is cardiovascular problems. But just as they can be a problem, they can also be something that we can manage and we can sort of mitigate, and that does lower our risk. So I've got two sets of graphs up here. This first graph up the top is showing sort of the risk of developing dementia years after a study, and these three lines depending on whether someone's blood pressure is stable in the bottom panel in the green, in the tan if there's an average blood pressure fluctuation, or if it accelerates. So as you can see, over the course of 20 years, we see in the people who have accelerating or increasing blood pressure a much higher risk of the development of dementia, whereas people who are maintained and stable have a much lower risk. Below this is some evidence from a very large heart disease trial called the SPRINT-MIND trial, which showed that if you actively lower blood pressure through the use of blood pressure medications, you can reduce the risk of developing dementia over the course of 5 to 7 years by roughly 10 to 15%. I'm looking, I should have blown that up, but a substantial percent. I should have looked at that a little bit larger. The eye health is also good. We'll get to that in a minute. But what I will say is the taking care of your heart, taking care of your cardiovascular system is taking care of your brain. And it's probably a theme I'm going to go back to, but good body health is just good brain health. It's all interconnected. A lot of people, a lot of questions we got were about sort of diet and, what is the best diet for dementia? I feel that the jury's still out on necessarily the single best diet. However, we know what's not good. What's not good is high amounts of saturated fats, high amounts of salt, often because they lead to all of the cardiovascular problems that I just laid out. Excessive alcohol intake is also bad. Poor diet can also increase this sort of inflammation where the body sort of starts attacking itself as well, and over-inflammation in the brain and swelling. We do get a lot of talk as well, and a lot of people come to us at different times and talk about different supplements. We don't have any conclusive evidence to show that any supplement is conclusively beneficial at slowing or stopping. And I don't think it's any better than just having exercise, having a good diet, and cutting down on sort of excessive alcohol and saturated fats. Moderation in moderation is, I guess, the watchword. So smoking. We often hear about smoking in relation to cancer. It's also not good for dementia. I will say that not only is smoking not good for dementia, how much you smoke is also positively correlated, I guess. The more you smoke, the worse risk you have for dementia. Up on the top right here, this is a per day cigarette smoking, and as you can see, this is a pretty straight line in terms of percentage risk. That said, every day you don't smoke is a day that's good for your body, good for your lungs, good for your heart, good for your brain. On this bottom right graph here, you can see these are the never smokers down here. This is taken from if someone quit 9 years ago is the next dot along, quit within 9 years, and then current smokers. Every day you don't have a cigarette is doing you good. All right, I've got to run. Okay, sleep. Sleep is our body's deep cleaning mechanism. It is very good to get good sleep. One thing to note as well is sleep occurs in rhythms, and it takes you a while to get to the best junk clearing part of sleep, which is what we call slow wave sleep, or stage 3 in that wheel going around. Sleep tends to go in cycles of around 2 hours, and you sort of drop in and out of stage 2 and stage 3 and stage 4 sleep. Good sleep habits are really important for maintaining brain health, because the worse the disease progresses, also the worse your sleep quality will progress. The less time you actually get into stage 3 sleep, the less slow wave sleep you have, the less junk you're cleaning out of your brain. So try to aim for 7 to 9 hours. Try to have a regular routine without long afternoon naps, less than an hour if possible. Try to remove sort of excess distractions, and sort of obviously excessive caffeine does not help you sleep generally. Some people don't feel the caffeine, but me, it's like, it sets me off, so definitely not for me. In addition to sort of a lot of these physical health, mental health often also plays such a large role in terms of our relationship to our physical health as well, and you need to take stock of that as well, thinking about sort of long-term dementia risk. So this study here you can see in terms of people who were lonely versus not lonely, we have a much higher incidence across a 10-year period of people who were isolated. Depression is a major comorbidity for dementia and can lead to its own levels of worse brain health in addition to having dementia. Engaging with either family, friends, other social networks really is helpful at reducing that risk. Another thing that is important and people often talk about is, oh, should I learn a new language? Maybe. We do know that low education is a risk factor for dementia. Down the bottom of the graph, the bottom of the slide, there's a sort of comparison of studies showing that there's a reduction in risk in adults with higher levels of education and who are at work. But there's nothing to say that if you're not actively pursuing a degree, which many people are not in their 60s and 70s, there's nothing to say that you can't still engage in terms of doing difficult puzzles, difficult mental exercises. This does help in terms of lowering the risk of dementia. This graph up the top here shows that people who have an additional activity and engagement of cognitive activity do have a slightly protected status for the risk of dementia than people who do not. Dr. Newhouse mentioned sensory loss. So again, these are sort of big meta-analysis studies of hearing loss and vision loss. But essentially the take-home point is in both of those red boxes. So as you can see on the top of those two tables is the risk of people who have vision loss for late developing dementia versus not. And to the right is increased risk. And as you can see, all of those bars are pointing to the right with increased risk as well as the overall. Same for the second bar chart down the bottom, which is talking about hearing loss. Why is both vision and hearing loss? Well, I think both the vision and hearing loss are directly related to so many things that we do. How do you engage in social activities? How do you drop that level of social isolation, that intellectual stimulation? All of that is challenged, and the independence is such an important thing for people as they get older, especially with cognitive decline, and it drastically goes down with losing these sorts of sensory faculties. And the last thing I'm sort of going to say is sort of in sum, and I know I didn't get to all of those risks, but I really I like this slide that or figure that was out of a recent paper in the Lancet, that there are multiple factors in our control for trying to reduce our dementia risk. It's not going to reduce everything. We can't control genes. We can't control our age. They estimate in this paper that potentially up to 45% of risk we can control. I will say that also these are not sort of quick fixes, changing diet, changing exercise habits, sleep habits, cardiovascular health. All of this is lifetime health. So against that, this is kind of I think of this talk as a little bit rehearsing my health class as a kid, that just good body health really does lead to good brain health. But the data bears that out, and that across the board, through every one of these factors, we do see that these potential changes, the earlier that they are engaged, can mitigate some level of risk. And I think we're done now, apart from Q&A. So thank you for staying with us. We appreciate you all for coming. And how are we doing it? Yeah.
And so now we are just going to open it up for questions. So we'll have Dr. Newhouse, Dr. Wilson, Dr. Andrews, Dr. Comley. So please.
Are you going to moderate, Blake, or shall All right. I'm being told I should moderate. All right. I'll just add just one other comment to what Dr. Conley said. You know, when we think of all these risk factors for dementia, we can think of them sort of in the opposite way. Like, what could we do, even in our older age, to begin to improve our risk factors? And what we're learning, especially through some of the work that Dr. Conley has done, is that we can change things even quite late in the game. And so we should not be discouraged if, you know, we've eaten a lot of bacon over the last 50 years of our life, and a lot of smoked sausage, and a little too many beers. But the reality is that I don't think we're asking ourselves to make radical changes. I think what we're doing is we're identifying the things that we can get smart about, and we can actually start to be actionable. And so exercise, social engagement, learning, blood pressure control, hearing control, all of those are modifiable even quite into our senior years. And so we shouldn't feel like, oh gosh, you know, all those things he listed, you know, how am I going to go back to my 20s and 30s and do that? It could still help, even now. All right, questions? We'll start way at the back in the white shirt.
My question is, could you comment on, is this something that is occurring more commonly today? Are we just able to diagnose it better today? Is it something about our lifestyle today? Because I also have some gray hair, and I don't recall there being this much Alzheimer's and dementia. Are we living too long, or longer than we used to? Why is this so prevalent?
Yeah. Well, I mean, dementia was described as far back as the Bible, right? You can go into the Bible and find descriptions in Ecclesiastes and other places about dementia. So it's not a new problem. When I went to medical school in the 1970s, we thought Alzheimer's disease was a rare disorder that only occurred in people under the age of 60. And it was only in the 1980s, late 70s, early 1980s, that people pointed out, well, geez, if you look at the brains of people that had, quote, senility, they look exactly like Alzheimer's disease. And so, yes, the definition, our understanding has broadened considerably. The other thing that has changed is that we are living longer, and so we have to live with the consequences of that success. And one of those consequences is that, you know, when my father began to become demented, my brother, I thought, made a very interesting comment. He said his body has outlived his brain, right? Because he was a very healthy man. And I think what's happening is that we're now being made aware of all of these problems because men aren't dying in their 40s of cardiovascular disease like they were when I was a medical student. And so yes, I don't think we've outlived our usefulness just yet. So I do think that we are, and we have much better ability to diagnose now. Right? So we can start to identify these earliest stages. When I started in this business, we didn't consider people having Alzheimer's disease until they were very impaired, frankly. And now we're looking, saying, hey, maybe we can look back and see just the earliest signs of memory loss. So yes, you're absolutely right. We're much more sensitive to it. I don't know that the prevalence has really changed. We can just see better. Our eyes are clearer now, and we can see what was always in front of us that we didn't see before. Next question. Yes.
I was wondering if there's been any kind of study to see if there's any connection between poor dental health and the risk of dementia. My mom grew up very poor, daughter of ordained Methodist ministers, had no dental work, and she, into adulthood, always had all kinds of dental and gum issues. And I kind of wondered if there was any kind of study that had shown any correlation to that.
Yeah. So there is a little bit of data actually on this. And people have been interested particularly in periodontal disease and dementia. So there has been a flurry of interest in this over the last decade, I would say, and I can remember a few presentations at some meetings that we've been to where people looked for bacteria in the brain that originate from the mouth. And so there has been some suspicion that there is a worse incidence or higher incidence of Alzheimer's disease in people with poor periodontal health. There have been some attempts actually to treat patients with drugs that were designed to combat those bacteria. That has not worked so far. But I think there might be actually a story there that we need to pay attention to. In the black shirt.
Is Alzheimer's a terminal disease?
Alzheimer's, do you want to talk about that, Patricia? You're working in closer to that area than I am.
No, go ahead.
The answer is yes. It is a terminal disease, and it's a terminal disease because the brain begins to fail. And basically everything below the neck is just plumbing. It's there to support what's above the neck, right? I mean, the reason we have all of this is to support our brains because that's who we are. And so if the brain begins to fail, as it does, what I observe towards the end of life is people stop eating, they stop wanting to do things, they lose their humanity, and so really, yes, the final cause of death could be pneumonia, could be infection, could be all sorts of things, but sometimes the brain just fails. And, one of the ways that we teach medical students, I'm sure Dr. Wilson will endorse me on this, is that dementia is really chronic brain failure. Right? We have acute brain failure, that's what we call delirium. That's something quite different. But dementia and Alzheimer's dementia is chronic brain failure. Sir?
Have there been any studies about fasting and its impact on dementia, like water-based fasting?
Nothing is coming to mind immediately. You're talking about intermittent fasting?
Sure, like 3 or 4 days at a time.
Yeah. So what he's referring to is that there have been some suggestions that fasting, intermittent fasting, is maybe good for health. The data is mixed on that, I would say. There was an initial enthusiasm a few years ago. I think some of the later data isn't quite as positive. I'm not aware of studies that have tried directly to look at that, mainly because it's such a hard study to do when you think about, would I have to have people intermittently fast for years or decades? It's really a tough question. You'd have to almost go back and ask, right? Like how we study diet. So I don't have any data on that. Yes, ma'am.
Can you speak to the new studies that are looking at lower LDL, less than 70, and effect on decreasing dementia?
Okay, do I know any data on that? I am going to admit that I don't know about really radical reductions in LDL cholesterol. We know that reductions in LDL cholesterol are important for cardiovascular and brain health. I don't know of specific data below 70, but maybe one of my colleagues does. Travocan, turns out, is a plant alkaloid. We get a lot of our drugs from plants, right? So nicotine actually imitates one of the neurotransmitters in the brain, actually. It was identified as far back as the 1920s that it actually binds in the brain. And we know from decades of work that nicotinic receptors in the brain are lost in Alzheimer's disease. And we think that's important. I've spent almost 40 years trying to study the question of what do nicotinic receptors in the brain do. So we developed a series of studies over the last 25 years that have looked at whether if we stimulate those receptors without cigarettes, can we enhance memory functioning? And the answer is maybe. And so the MIND study is designed to test this in a long study design of up to 2 years of treatment. Just by nicotine itself, no smoking, just a patch. And this is, we ran into COVID and that set us back and lots of other issues, but we hope to have answers starting later this year. We did publish a paper in 2012 that showed positive effects of nicotine in mild cognitive impairment, but that was a small study, only 72 patients. And so we need a much bigger sample to do this. If it works, nicotine is as cheap as dirt, right? I mean, you can buy it in Walmart. So, there's no patent on it. Nobody, nobody's going to charge thousands of dollars for it. So, is it a cure? No, it's never going to be a cure. Could it be a tool as one part of treatment? Possibly. We'll know soon.
But we shouldn't take up smoking, though.
We should not take up smoking, or vaping, or chewing. I'd like to say it's a good drug, but it's a bad delivery system. Ma'am.
Have you did any or heard of any studies related to UTIs and the effects, a long-term effect on seniors related to dementia and the effects that happen? Dementia diagnosis was after the UTI and after issues from that.
Dr. Wilson is stepping up here so I can rest my voice.
You're asking a really important question. So how many of us have cared for a loved one, an older loved one who's had a UTI and then suddenly gotten very confused? And then, maybe has never returned back to that previous cognitive baseline. Okay, so I think what you're talking about there more than likely is someone who developed delirium, which is that acute brain failure that Dr. Newhouse was talking about. And delirium looks like acute confusion that can happen over hours or days. They can sometimes be disoriented, not know where they are, what's going on, who their loved ones are, and have other changes in their thinking and behavior, like experiencing hallucinations for the first time, for example, or having some unusual thoughts. So that delirium can sometimes be challenging to treat and manage. We don't have really effective treatments for that. It sometimes just has to run its course, and we have to treat the underlying problem, that UTI, for example. Delirium can emerge because of other problems as well that affect our health. So as we've been talking about tonight, a lot of the things that affect our overall health affect our brain health. And so acute infections like urinary tract infections can cause that acute confusion called delirium. What we're understanding now through research that's also been happening here at Vanderbilt is that episodes of delirium, especially as we get older, we're more vulnerable to the effects of delirium. And that can cause more permanent cognitive changes that look a lot like Alzheimer's disease. And so we're trying to understand what happens in the brains of those individuals who develop delirium and why some of them remain cognitively impaired.
Do you have any studies related to those particular issues?
I do, and I'll be happy to share that with you. If you want to come up afterwards, I'll give you this reference. Great question. Maybe you right there in the blue shirt? Yes. Oh, you,
I'm sure you've seen the reports recently that the shingles vaccine may have a preventative effect with respect to these issues. I'd like to hear about that, but secondary question, we have a daughter with Down syndrome, she's 45, doing great. If there's anything to this, would this suggest early vaccination might be appropriate? It's normally age 50. Would it make sense to have early vaccination?
Yeah, it's a great set of questions. So what the questioner is talking about is the recent data from the UK, actually, that it was an amazing study. It was done in Wales, and what they did was they had this sort of artificial deadline, like if you were over 65 on a certain day, you couldn't get the shingles vaccine, but if you were born one day earlier, you could. And so they had a sort of natural control of people who did and didn't get the shingles vaccine. And what they showed was that people who did get the shingles vaccine, because they were born literally one day earlier, had a lower risk of dementia 10, 15 years on. So, amazing, huh? And so it suggests, well, what is shingles? Shingles is a herpes virus, okay? And it's, sadly, it emerges, it's the chickenpox virus, and it emerges from, it's been resident for many of us since we were children, since we had chickenpox. And now it reemerges. Now, we don't understand exactly why that is, that shingles vaccine prevents or seems to reduce the risk of dementia or Alzheimer's disease, but it sure is something that made me glad that I got the shingles vaccine. In fact, I think I got the first one, and then they came out with a newer one, and I got the newer one too. My wife said, "You're getting that one too." And so I got that one. So I'm so anti-shingled now. A room full of kids with chickenpox, and I'm great. So for a patient with, or individual with Down syndrome, it's an excellent question. Should we be encouraging them to get shingles vaccine? If it was my daughter, I would say yes. What's the downside? I can't think of a downside, frankly. So, yeah, great question. Yes. We got one more. Time for one more?
We'll be here for more questions.
Yeah. We'll stay as long as you want.
Okay, I'm in the AHEAD study, and I'm about ready to finish the study in about another 6 months. And I want to continue on with the added benefit. Are we excited about that? I mean, I know that it's here, FDA approved the medicine, but are we happy? I mean, are we really seeing any progress?
So when you say we, do you mean the royal we or the editorial? So we are excited. I mean, so I guess, Carla, what you're asking is, do I believe this will work? I think the odds are that it will. How large the benefit will be, it's hard to predict at this point. Of course, we don't have any data, and we won't have data. This study will probably not read out till 2028, actually, because the last patient entered October?
October 2023.
So October of 2024.
24, yeah.
So the last patient, and that patient has to get 4 years of treatment. So this study's not going to read out till 2028. So the blind won't be broken until then. So that's why they're offering open label, because there may be benefit. And so we don't want to make everybody wait until 2028. But I am cautiously optimistic that in this case the juice will be worth the squeeze. I know there was one lady back there in the mask that I wanted to let her ask.
I wanted to ask a question. Okay, I took care of my mom between 2015 and 2023 when she was 80 years old. And so when she addressed that about the UTI, we kept taking her to this older doctor, and he kept giving her medications for UTI. Then the overall effect of that, she got to the point she had hallucinations real bad, and like I said, all of the issues of couldn't walk, and a lot of other major issues that came from that. So my thing is how do you let other families know to take better care of your parents in the sense of not letting the doctors give so much of this other stuff and try other avenues, because I would hate to see that happen to some other family members of not knowing and not trying to find other avenues, if that makes sense.
Tricia, it's this one? Yeah, I'll let you address that.
Well, when it comes to delirium, I think we've learned a lot over the years. And I think part of our job is also providing a lot of patient education and information. There's really good, Vanderbilt, the SIP Center has a really good website with patient information and links. When my own patients are suffering from UTIs, I even send them the links to this website of like if you if you're experiencing delirium or if you're at increased risk for delirium or if they're going to a surgery, that's another good example. One of my patients is getting a hip surgery, I educate ahead of time. So I do think the wave is changing. I think we do a way better job at educating people about delirium. When I was in medical school, which wasn't as long as Dr. Newhouse was.
That was in a past century. This is in med school.
We were taught that delirium was just, would happen for a few days, and after it was resolved, everything was okay. And now, I learned in residency that that's not the case. We educate our residents in identifying that early on in our medical students. So the wave is changing. And part of it is, we want to help our patients and our participants in how to advocate for themselves. We're always happy to, talk, even if you're not our patients, but you're a participant or talking to your doctors. You guys probably all, Sarah Nelson, our wonderful nurse practitioner. She's more than happy to talk to your providers, and we are as well.
Can I add something to that I've done, I've learned in the process of caring for my mom? I'm her caregiver now. I give her the dehydration drink, IV, it's a powder form. I've been able to keep her from having UTIs because I can't make her drink maybe more than 1 vial of water, but if I can put that powder in that 1 vial of water, it's like 3 bottles of water, and it keeps her from having a UTI. So I suggest anybody caring for seniors to start that rehydration drink to prevent the UTIs. That's what I've been able to do over the last 3 years, is prevent the UTIs. She's diagnosed with dementia, have that issue, but I don't have the UTI issue, so.
I think we'll finish with this one final comment. So Vanderbilt has been a leader in trying to understand risk factors for delirium, and that's what we were talking about here these last few minutes. And also leading the charge in terms of preventing and treating delirium. And we know that when folks have Alzheimer's disease or other forms of dementia, even as we age, we're at much higher risk for developing delirium when we have medical problems. And so it's one of the reasons that in our care bundle that we talk about when we teach intensive care unit doctors how to treat, prevent, and manage delirium, it's a care bundle called the A to F bundle. And the F means family. And family, the patient's family, is one of the most important parts of the care and evaluation of that patient. So I think all the things that we're doing here tonight by educating ourselves, whether we're a research participant or we want to be a research participant, or we're that family member, that support system that's supporting that person participating in research, you're all important, and we want to thank you all for taking the time to come here tonight. I think Blake may have one final comment. No?
What's delirium? What is delirium?
We're going to finish up now, and we'll let everyone break, but we're happy to answer questions right here. Okay, thank you.
So I want to thank everybody for coming tonight. We'll stay here as long as you'd like to answer questions. Thank you for all the work that you do. We can't do anything without you. And so we want to applaud you. Thank you. Ice cream, lots of unhealthy things to eat. And enjoy.
We want to thank our sponsors, including the Alzheimer's Association, ACMU, and